All right, good evening. My name is Natalie Dillman. I'm the programming coordinator here at Way Library. Thanks so much for joining us on a Thursday evening. Before we get started, I just wanted to talk about one program that may be of interest. Next week on Wednesday, November 22nd, starting at 10 a.m., we're having our Tom Hanks movie marathon. It's called Hanksgiving. So we're gonna watch 3 Tom Hanks movies. There will be cookies. So if you need a break from class. Is class over by then? You got it? No. Okay. Well then, you can come get cookies afterwards.
Oh, no, right, no class.
No, right. Okay. So I will introduce Dr. Jolie Sheffer. She has served as director of the Institute for the Study of Culture and Society at Bowling Green State University since 2016, and she is a professor of English and American Culture Studies and an affiliated faculty member in the Women's Gender and Sexuality Studies program at UVSU as well, and she will introduce our speaker.
Good evening. Welcome to tonight's ICS Faculty Fellowship Lecture, Community Health Workers, Stress Reduction, and Racial Equity in Infant Vitality, presented by Dr. Justin Rex. As Natalie mentioned, I'm Jolie Sheffer. I am the current director of the Institute for the Study of Culture and Society at BGSU, which functions as the university's public humanities center. So we do programming that is designed to sort of engage both the campus and the wider community in conversations about important issues for our society and for our local communities. And in particular, the Faculty Fellowship Program features BGSU instructors who are doing important work to help us understand and transform the institutions that structure our lives. And I'm very pleased that this is my last event as director of ICS, but Dr. Valeria Grimberg-Pla will be leading events for ICS starting in January. Before we formally begin, I do want to give a land acknowledgement statement. Bowling Green State University and its campuses are situated in the Great Black Swamp and the Lower Great Lakes region. This land is the homeland of the Wyandot, Kickapoo, Miami, Potawatomi, Ottawa, and multiple other indigenous tribal nations, present and past, who were forcibly removed to and from the area. We recognize these historical and contemporary ties in our efforts toward decolonizing history, and we thank the indigenous individuals and communities who've been working on living on this land from time immemorial. When I acknowledge this land, labor, and that history of systemic racism, we do so as a way to show respect to indigenous communities, but we also want to think about the ways that we can engage in action that works toward creating greater equity and justice in our communities. So our talk tonight, we'll talk about some of the things that we can do to mitigate some gaps that we see in health equity, but I ask each of you to think about the ways that as you go about your lives, you can work to reduce inequality, whether that is through representation, being part of community organizations, or in what you choose to study and do in the world. I also want us to recognize the often invisible labor of the people who have helped prepare this space and will help clean it up and get it ready for the next use by other folks. And I want to give a big thank you to Way Public Library and Natalie Dielman for being wonderful partners in helping us to share the work of our faculty fellows and of experts across BGSU who are able to come into the community through spaces like this to share what they're doing and learning. I also want to thank the College of Arts and Sciences at BGSU for their financial support, and very importantly, I'd like to thank ICS graduate assistants, Emmett Bilal and Allison Sporing, and they are here tonight. They have helped prepare for all of the things that lead up to this event. And then we have 2 interns this semester who are not with us this evening, but have also helped to prepare for this event. So I'd like to thank Autumn Dunaway and Delana Harris for their work as well. And with that, I will stop talking, and I'd like to introduce you to our Fall 2023 Faculty Fellow, Dr. Justin Rex. Dr. Rex is an associate professor in the Department of Political Science, and he's also a research fellow at the Center for Regional Development at BGSU. Tonight, Dr. Rex will present findings from an evaluation of the Northwest Ohio Pathways Hub a nationally recognized best practice program model that pairs at-risk mothers with community health workers who help connect them to services that reduce pregnancy risks. And so he will share with us stories from mothers and community health workers about the challenges and stresses they face, as well as data from interviews and surveys that help to quantify the impact that community health workers have to reduce mother stress and provide support that help mothers and children thrive. Finally, a few quick announcements. If you are here as a student and you need confirmation of your attendance for us to communicate with your professors, there's sheets back there that you can sign in at the end with your name, email address, and the class for which you would like credit for this. We also have some t-shirts, so if folks like t-shirts at the end, we can provide those. And we also encourage you'll see periodically at the end, there are QR codes for surveys after the presentation. We'd love your feedback on this event. And if you are someone who doesn't have a smartphone, we have some physical copies of those surveys at the back of the room as well. And with that, please give a warm welcome to Justin Rex.
All right, thank you, Jolie, and thank you to Natalie and all the folks at ICS who helped set up the presentation of the event for this evening. It's much appreciated. A few more thank yous before I get started into the presentation. This research was done from a grant funded by the state of Ohio. The Ohio Department of Higher Education has some funding to research infant mortality in the state and other public health problems. And so that's partially where we got the funding to do this. And ProMedica and the Hospital Council of Northwest Ohio were also partners in this project and part of the grant team, and gave a lot of input and insight into the issues that we were looking at. And as Julie mentioned, I'm part of the BGSU Center for Regional Development, and they partnered on this as well. We've also I did a presentation yesterday, and it was a hybrid presentation, and most people came online and not in person, so we've got some mugs back there. If you want a BGSU mug with some candy in it, go ahead and grab one if you haven't already. Okay, so I'll introduce the research team because I'm presenting the research, but this is a very collaborative project amongst BG faculty and students and the other partners. And so myself, Dr. Nicole Pfeiffer, who's the director at the BGSU Center for Regional Development, Dr. Karen Johnson-Webb, a professor of geography at BGSU, Maddie Bennick, who is at the Center for Regional Development as well. Our grad students, Alyssa and Lydia, and our undergrad pre-med students who are also part of the project, Crystal Martin and Destiny Dorch. And we had a variety of folks from ProMedica in their social determinants of health department, as well as some doctors there, and then the Pathways Hub program I'll be talking about. The former director, Carly Salamoni, and Holly Papana were also part of the research team. All right, so those thank yous out of the way, I'll give a little overview of what I'll talk about, and then we'll dig into it. So I'll talk a little bit about infant vitality as a problem globally and how that manifests in the United States and also locally here as well in Ohio and Lucas County. And I'll talk a little bit about community health workers and what they do, and then talk about how they fit into the model that is going on in Northwest Ohio, the Pathways Hub. And then I'll talk about the research that we did related to those groups and some implications and takeaways at the end. So when we think about infant mortality, the way it's measured is the number of infant deaths per 1,000 live births. And so this is a selection of countries around the world, and the United States ranks fairly high given how rich it is as an advanced democracy. And so several countries, select countries here, as you can see, have half or even less the infant mortality rate in the US, although it ranks lower than some other countries. And so it stands out from other countries similar to it in that it's a very wealthy country, but has a much higher infant mortality rate than other countries similarly situated. So why is that? Well, I'll get into that in a moment. So this is a look at infant mortality statistics in the United States, and as you can see, Ohio is in the top 10 in terms of infant mortality rates. And so over the last couple of years, been about 8th or 9th highest in the United States in terms of statewide infant mortality. If we look at by county, Lucas County, which is where we did this study and where the hub primarily, though not exclusively, operates, and that's where its clients come from, Lucas County is one of the highest counties in the state of Ohio. So this is a problem globally, but also a very localized problem right in our backyard. Interestingly, if you look at the data historically, the infant mortality rates in the United States have been falling over the past 2 decades slowly. But last year, or this year, where they're looking at last year's data, showed the first increase in infant mortality in over 20 years in the United States. And so you can see it's a slight uptick here on the left chart. So given that this is current, the current data, they're not quite sure what the reasons are and whether this is an anomalous trend or whether it will continue to rise. And so, but I thought interesting to point out that we've seen a decrease, but recently a slight uptick. So here's the overall data from the past 20 years or so, and you can see that it's declined slightly. The other important thing to note about infant mortality is that it's not distributed evenly across the population. And so we see stark racial disparities and ethnic disparities in infant mortality rates. So here is a look just at the recent data from the last couple of years, just to show you that it's been rising for all groups, but it also demonstrates that the African Americans have the highest infant mortality rates in the United States, and that holds true for Ohio and local data as well. Depending on where you're looking and when you're looking, it's 2 to 3 times higher than the white infant mortality rate, the lowest infant mortality rate, or almost the lowest except for Asians. So here's a look at infant mortality in Ohio over the last decade, and so the top line here you can see is the black infant mortality rate, and then the greenish teal line is who identified as Hispanic, and the lowest is white Americans. And so you can see it's almost 3 times as high. The black infant mortality rate is almost 3 times as high. And so this is a challenge all mothers face, but certain mothers in particular. And so what might lead to the high infant mortality rate in the United States and when we see it lower in other countries? And so researchers talk about modifiable factors or protective factors that communities can help create to influence population health overall, which also could impact infant mortality. And so part of the challenge lies in improving clinical care, so hospitals and the individuals that moms are interacting with in the medical community. Partially we can look at health behaviors like tobacco use and smoking, and those things are associated with or are risk factors for infant mortality. And then there's a whole host of social, economic, and physical environment factors like housing, transportation, education, access to good jobs that also impact that. So those are called oftentimes the social determinants of health. In a new study that we're doing where we're talking with some medical providers, one of the doctors we spoke with says she likes to call it the political determinants of health, which I like better, and agree, because these are political choices that we make regarding how much we invest in housing or how much we do not invest in housing. So in a lot of ways, the infant mortality rate is often used by public health researchers as kind of a baseline metric for how we treat the health of our citizens and the political choices we make about how to allocate resources to address population health. So as I mentioned, we see these discrepancies, and so we talk about these protective factors, having a higher income, more education, better housing, that generally would reduce the likelihood of infant mortality. But what's interesting is that researchers who've looked at these gaps, particularly between African American and white mothers, those protective factors don't always hold. And so this is just one example that if you look at the degree of education, you would think that as your education gets higher, that's going to open you to more economic opportunities, better jobs, higher income, and so on. But when we look at the gap between black and white infant mortality, we actually see it rising for more highly educated women. And so that kind of poses a puzzle: is why are we seeing that? Because that's very counterintuitive. And basically, the other research I've looked at, and relying on, suggests that it's stress-induced racism. And so the stress that results from individual biases and microaggressions, but also the institutionalized racism that we see in practices, whether it's healthcare or employment and just general society. And so they can't find any other reason but that. And so that's suggestive that we know that stress is associated with preterm birth, so having your baby earlier than 40 weeks. It's also associated with lower birth weight. And so those are the biggest risk factors that would predict infant mortality. And so the research suggests that stress from that African American mothers are facing leads to earlier births, lower birth weight, which then increases the risk of infant mortality. So we see these racial disparities, and then it also, the challenge of just investing in these social determinants of health. We need more targeted interventions potentially, given that some of these protective factors like a better education don't necessarily translate into better health outcomes like we might expect. So this leads to a model. We talk about the social determinants of health model, and others talk about racism and discrimination as another key social determinant of population health. And so in a lot of these areas where we might want to make more investment, whether it's education, housing, and things, we see discrimination, racism embedded in those systems. And so to address infant mortality, not only do we need to address those social determinants of health, but also the biases that are within those systems that moms exist within. So one potential solution, not a comprehensive solution, that we looked at within this research is looking at community health workers and programs that employ them to work with moms to try to help fight some of those barriers that they may have and may contribute to this, particularly stress and mental health. So I'll talk a little about what community health workers are, and then I'll talk about the model that we looked at in Northwest Ohio. So community health workers, there's a lot of different terms that get used for these type of workers. Outreach workers, social workers, navigators within the healthcare system. That's really where the model developed, was when patients developed with cancer patients actually, and so they are facing a really complex medical condition and a really complex medical system, and so professionals would help them navigate the healthcare system, navigate insurance, navigate doctors, treatments, and so on. And so they're really like a partner that works alongside a patient to help them navigate the challenges that come with their medical care. And so community health workers provide a lot of different benefits. On one level, they can help build trust with the client, or trust with the patient. And so not all of, but a significant number of the community health workers we looked at in the Community Hub program, they were former clients within that hub. And so they've got a connection to the community, to the people that typically enroll in the program, and so they can build that trust, particularly in a system where there's a lot of distrust of the medical system. So they can offer, one-on-one help to help get you to an appointment or any other struggles that you may have. As I mentioned, the healthcare system is very complex, and so they can help navigate that system for clients. Oftentimes, they'll do health education. So the community health workers get trained, and other navigators get trained in, for example, new COVID protocols or COVID vaccinations when a new public health crisis comes up. And so they can get educated themselves, but also educate the clients that they work with. And then another big thing is connecting moms or their clients to community resources. And so maybe a mom is struggling with their landlord and are going to be evicted, and maybe wrongfully evicted, and so they can connect them to legal help to challenge that eviction. Maybe they need to sign up for cash assistance or WIC or other public programs that help mothers, and so they can connect and cut through the bureaucracy and help them navigate that system as well. So the Pathways Hub model relies on community healthcare workers and coordinates them into an overall model that tries to address some of these social determinants of health and a lot of the risk factors that pregnant moms face. And so, as I mentioned, we've got one of the leading examples of this model right in our backyard in Northwest Ohio. Is one of the early adopters of this model, and it's spread, as I mentioned, around Ohio, but elsewhere in the country as well. And so their model is really built around community health workers as the key liaisons to connect with at-risk mothers. And so the first thing that they do is help enroll clients. And once clients come into the program, they go through a risk assessment. And so they ask moms about their health history. Have you had any domestic violence issues recently? Do you have stable housing? Do you have enough food to eat at home? How's your stress level? All these different social determinants of health, they assess and put together kind of a risk profile. And then with that information, they try to develop a plan for how we're going to address the key risks that you want to address. And so that's where the pathways term comes from, is that for each of those risks that they identify, the mom has a pathway to connect, the CHW has a pathway to connect the mom to. So if you have unstable housing, the Pathways Hub works with the housing department, public housing department in Lucas County, and they have apartments and other rentals where they try to get moms into. So there's actually a set number of rentals in Lucas County for clients in the Pathways Hub. So figure out what the risks are, set them on a pathway to try to address that risk. And then they will meet with them regularly, typically once a month. It could be more depending on time or the needs of the mom. But they'll check in with them to see how they're progressing on these risks. A lot of times it's very informal, where they develop kind of a close relationship, like a mom or a aunt or just friend kind of relationship, where they may talk informally, and a lot of them talk through text very regularly as well to just check in, how are you doing, and things like that. So the goal of the hospital council, which kind of oversees this model, is that they're doing some of the tracking on what moms are doing. Are they getting connected to the pathways, and are they completing those pathways to reduce these key risks for infant mortality? The hospital council also does some training for community health workers on emerging health issues or new things that they're seeing. And so this could be anything from how to detect signs of depression and mental health, or training about COVID and new emerging health issues like that. And then the way the whole model gets funded is that the hospital council works with Medicaid and other organizations to essentially refund the money or pay for whatever these pathways are. So it's in the interest of Medicaid and these other organizations that are paying for healthcare, that if we reduce these known risks, it can save Medicaid and other healthcare organizations money. And so that's kind of how the everything gets funded. And the other thing I should mention is that it's a partnership. And so the community health workers are actually employed at community organizations around the Northwest Ohio area. And so some of them are nonprofit organizations, some of them are the health departments in the counties around Northwest Ohio. Some health workers are employed at the healthcare organizations, so at Mercy and ProMedica, the major healthcare organizations in our area. So the hospital council kind of acts as a coordinating body for the payment and monitoring all of the insurance and all of that technical stuff, and do the training for the community health workers who are all placed in these various organizations. So the hub model, as I mentioned, we've got one in Northwest Ohio, but there's a variety of officially certified models around the state as well. And there are some around the United States too. And so actually the former head of the Northwest Ohio Pathways Hub is now working for the national kind of body in the United States to kind of oversee and certify and monitor all the hub programs around the country. Okay, so you got an idea of community health workers and the model, and so our goal with the study was to examine the model and see what was working and talk to participants in the community health workers and also the moms who are participating. And so part of the motivation for the research is that there's been a lot of research on these social, political determinants of health, as I talked about just a little bit ago, right? That we know that countries that invest more in trying to have better education, more healthcare spending, and those broad social determinants have lower infant mortality rates. And we look at state by state in the United States, we see those differences as well. So states that invest more in those tend to have lower infant mortality rates. And so we know these broad kind of social determinants, these political policy decision-wise, and we also know that from the broad literature on community health workers and similar individuals that work in healthcare organizations that they're pretty effective. They help get clients to their appointments. They're associated with better healthcare outcomes for the clients that they work with because it would help them navigate that system better. And some of the research on the Pathways Hub model that had been done prior to the study we're looking at showed that that infant mortality rates are lower for moms who are enrolled in the program compared to moms in Northwest Ohio. And it also tends to save money, that it's more efficient in that respect, that moms tend to have lower healthcare costs when they're part of this model, because there's some preventative measures being done, right, to address those risks that may lead to poor healthcare outcomes. So some places where we're trying to kind of fill that gap in the research or add to the conversation is that there's not as much on some of the ground level mechanisms that support infant vitality or help explain why we see some of these disparities. And although there's been a lot of research on community health workers, they've mainly been in other kind of medical contexts. So as I mentioned, cancer and other kind of complex medical conditions like that. There hasn't been as much research on community health workers that work with moms. And also, this was kind of surprising as I was digging more into the research. A lot of the research on community health workers either talks to community health workers or talks to medical providers and says, hey, your mom, the moms that come into your office, or the clients that come into your office are working with community health workers. How have you seen impact of that? How does that help out your practice? There hasn't been a lot of research on talking to moms or other clients who work with community health workers and what's their opinion on, is this a good thing? Do I like my community health worker? Has it made an impact on me? So that's where we're trying to add a little bit to the kind of the academic conversation around some of these issues. So to do that, we did our study we got the funding just before COVID set in and did the study and a lot of the interviews during the first couple of years of the COVID crisis, so 2020 to 2022. And we were doing, the data I'm presenting here tonight is a kind of a subset of a broader evaluation we did of the Pathways Hub model. And so what I'll talk about tonight are monthly interviews that we did with moms who were part of the program. And so we interviewed 41 moms, and they completed between 3 and 7 interviews over the course of their months in the program. And so we would check in with them each month and ask them a little bit about what's been going on, how's their stress level, how's their health level, mental health doing, and also talk about what kind of services they've been doing in the program, how's their relationship with their community health worker, and just trying to assess what their experience has been like, what they like and dislike about being in the program. So overall, we did 200 total interviews with moms. And then at the end of the study, we also did a survey, and so sent that out to all clients that are part of the Pathways Hub program. And so some of the moms we interviewed answered the survey. We also got a broader swath of moms who were part of the program. So as I mentioned, we were trying to understand their experience, and tonight I'll be talking about some of the data where we asked specifically about their stress and mental health and how that was impacted by being in the program. And again, that was important for us, particularly when we think about those inequities, given that stress seems to be, based on other research, one of the drivers of the racial disparity that we see in infant mortality. So here's a quick demographic look at the respondents to our survey. So as I mentioned, we had 119 moms, and almost 60% identified as Black or African American. And so that's not representative of the population in Lucas County, but it is representative of the clientele that are in the hub. So it's majority African American moms who are in the program. So this looks at the moms that we interviewed and looks at their age range, and so they tend to be almost all of them fall in the 18 to 29 age demographic, and then a few a little bit older than that, which is expected given that's when people tend to get pregnant. And then the racial breakdown of the moms that we had in the study was almost half were African American and about 30% identified as white. And about half of them were single, the other half were partnered or married, and a few divorced. So let me get into some of the data from the survey and then the interviews that we did with moms. So as I mentioned, when moms enroll in the program, they do a risk assessment at the beginning with their community health workers. So it's a pretty long interview where they talk about their health history, but also any other risks that they're facing at that time. And so there's a whole host, there's about 20 or 25 risk assessment questions they ask, and these are all risk factors associated with infant mortality. And so, things like tobacco use, needing help with childcare, housing, had they had a previous pregnancy where they had a low birth weight baby or a preterm birth, because that's a big predictor of infant mortality. And so ask them a bunch of these ones. And so on the left, you can see here that stress was identified as a risk factor for almost half of the moms. And so that was one reason, among others I've already mentioned, that we wanted to look at how did the program impact their stress. And so when we asked moms in the survey, we said, on a scale of 1 to 10, tell us what your stress level was like prior to your time enrolling in the program. And so on average, they said it was about a 7 out of 10. And they said after enrolling in the program, it went down significantly. So on average, about 3.5. So one little piece of data to suggest that their stress level was being impacted. We look at just the raw numbers in terms of the survey. Overall, 101 moms said that their stress had decreased at least somewhat. About 8 said that there had been no changes in stress, and a few moms, 6, said that their stress had increased after enrolling in the program. We also asked a few kind of general questions about their feelings and mental health. And so one thing we asked was, how did being in the program impact your overall feelings of hope? And about 80% of moms said that it had increased or significantly increased their overall feelings of hope. You can see that in kind of the darker shaded parts of the pie chart there. We also asked study participants about how their stress level had been impacted in each of those interviews that we did over the course of 7 months. And so what we also saw there, interestingly, is that there were slight decreases on average in the stress level even once they had enrolled in the program. So we saw a big drop initially, but then small drops on average in the subsequent months when they were enrolled in the program and doing interviews with us. Also, we asked about change in overall feelings of security. Here it's slightly fewer, but still a significant majority of moms said that their feelings of security had increased or significantly increased. Similarly, a majority, about 56% of moms said that their overall feelings of safety had increased or significantly increased. And lastly, we asked in the survey about their changes in their overall feelings of isolation. And we saw that a smaller number, slightly less than half, said that their feelings of isolation had decreased or significantly decreased. Again, we were doing this at the time of COVID, so I don't know if that's in some ways, maybe that's a very positive finding, that even during a time when people felt very isolated, that feeling had gone down for the moms. So now I want to talk a little bit about the interviews. And so I've selected some quotes here to show that why we think that it's community health workers in particular who are the source of the stress reduction and kind of the improved mental health feelings that we identified in these broader survey data. And so during the first interview we did with moms, we asked them, how has your stress level been impacted by being in the program? And then we asked what specifically about being in the program had impacted your stress level. And so these are some of the responses Mom gave to that question about what helped them by being in the program. And one mom said, honestly, my CHW as a person. If she's at my doctor's appointment or she comes to see me, it reduces a lot of stress if I mention something there and she calms me down. Her being there and knowing she's at the office is really calming and stress reducing. Another mom said, I can talk to her about anything. I feel like she's a family member. And so these kind of quotes are representative of a broader theme that we found, that moms had a really strong interpersonal connection with their community health workers. And so a lot of them use language like, she feels like my aunt or a sister. And so that's a theme that we see in the broader research about community health workers, is that they offer an interpersonal connection and sometimes a kind of a dehumanizing medical system sometimes. They also were able to offer connections to supports. And so one mom said the little stuff she did was big for me. Another one said, when I was about 7 or 8 months pregnant, I was nervous about having what I needed since I didn't have a baby shower, and she looked out for me, and I appreciate that. So sometimes it's just small things like connecting them to get a car seat, a crib, diapers, those things that some moms may not have. And so they were able to connect them to community resources there where they could get some of those basic needs met. Additionally, they were able to connect them to some broader social resources as well. So one mom said she helped me find a house that I own now. She pointed me in the direction of Facebook Marketplace because realtors were a headache. And she said it's perfect for the kids and a great location. Another mom said she helped me get my WIC. She actually called the office because I hadn't heard from them for about 3 weeks. She called them, and the next thing I know, they called me the next day, and I was able to get my card. And so they're able to cut through some of the bureaucracy and red tape, particularly since we were talking to moms during COVID. A lot of the social service systems were really overburdened with people who lost their jobs or facing tough economic circumstances. And so almost all the moms who applied for programs like that told us about the challenges they had signing up. And the community health workers were kind of able to cut through that red tape. Another mom said, yeah, it's helped with stress for sure. I send stuff to her and she faxes it to them, in this case, Job and Family Services. And I think before, when I dropped stuff off, they were like, this is just from a person. But when she drops it off, they're like, oh shit, this is from Pathways, and they do it faster. And so the community health workers kind of have a relationship with some of the people that work, at these government agencies, and so they're able to kind of cut through that. Okay, so I want to talk about just a few kind of broader conclusions and implications, and then give you all some time to ask any questions if you have any. So one big conclusion, partly from our research, but also from other people who studied this model, is that there's evidence that the model is effective for addressing issues related to infant vitality. As I mentioned, some of the Hub Zone data looking at infant mortality rates for clients in Northwest Ohio who are enrolled in the program versus those who are not, we tend to see lower infant mortality rates. Additionally, from our findings, the finding that being part of the program and having that relationship with the community health worker reduced stress for the moms, among a lot of other benefits that they had about being in it. And we think, based on talking to the moms, that they identify the community health workers as the key thing that was helping reduce that stress among the other services that they got. As I mentioned, a little bit of the limitations, we did this during COVID, so it's a little bit time bound, and it's geographically bound given that we're only looking at one hub. And so there tends to be a pretty standard model for how they're used in other areas. They try to certify and kind of accredit the programs, but whether or not it's generalizable to other ones remains to be seen. Maybe a future study we do, or maybe you're inspired and you can do that as a research project. So thinking about the policy implications, obviously there's a need, given what we know about infant mortality, to address these broader social determinants of health, like more affordable housing and more education spending and things like that. Additionally, given what we found about the Hub program, I think that's a model that could be better supported and ramped up, partly at the institutional level. Speaking to some of the community health workers, they feel like they're in kind of a limbo state in some of their institutions, that they in the healthcare institutions, for example, where there are a significant number of them, but they feel like they're overburdened, and a lot of the community health workers we talk to have client loads of 30 to 40 moms that they work with, and so there's, some of the data that's looking at these around the country is that there's just a significant shortage of these type of people to help out, and so that's something that states or the federal government could invest more in. And then, there are particular services that the hub offers that could be supported as well. And the other big thing is that a lot of the moms that are in the program may be in it over the course of multiple pregnancies. And so the important thing about these benefits is that they can extend to future pregnancies. There's kind of future wins in addition to kind of the present wins of helping these moms out. So as I mentioned, a lot of these things can help address infant mortality more broadly, but given the gap, there also need to be some targeted interventions to address the racial disparities that we see. And so a lot of researchers talk about having more social supports for expectant Black mothers, and a program like the Hub, I think, is filling that gap, given that they're serving a predominantly African American population, though not exclusively. But additionally, the Hub has been rolling out some new programs that may help out with infant mortality too. So using more doulas, midwives, and birthing centers to have, we know that moms in traditional medical settings have higher, African American moms in particular have higher mother mortality rates from these healthcare settings. And so partnering with doulas and midwives and others who have different approaches to birthing, but also tend to be more racially match the moms and more diverse than oftentimes very white healthcare institutions helps. And so kind of having moms and medical providers who have that match, actually research shows that leads to better birth outcomes and better health outcomes for moms as well. And then additionally, right, there are lots of things that hospitals can do to reduce some of the biases that exist within them. And that's something I'll talk about in just a moment, and some of the other studies that we're doing based off of this is that a lot of the biases within the systems that moms exist in need to be addressed as well. So lastly, to wrap up, one of the key things that we found from doing these interviews and just talking with moms about their health history and their birthing experience was that a lot of them felt had a lot of negative experiences with their healthcare providers, whether it's the OB that they see or the doctors that were delivering them or their staff that they had at hospitals, and heard a lot of harrowing birth experiences from the moms. So that led us to get some more funding, and we're doing kind of wrapping up a current study where we did a lot of interviews with moms, but also medical providers in the area to look at how they can build better relationships and also reduce some of the biases within that. And then another key thing that came out of that study, and the first one was looking at transportation access to healthcare is particularly lacking in a rural area like Wood County, but also even in Lucas County. And so we're doing a study related to that to look at how providing alternative transportation options could help get people to their medical appointments more frequently. So I've talked a lot. Thank you all for listening, and happy to answer any questions or hear any feedback that you all have. Thank you.